The first adjustment that we'll go over is the anterior medial tibia, which is also known as an externally rotated tibia. So when we're adjusting the tibia, we only adjust the proximal portion of it. We don't do anything with the distal tibia. And in the last video, we looked at how you motion the tibia. So you're internally and externally rotating the lower leg and looking for the tibial plateau to move into your thumb or away from your thumb, into your fingers, away from your fingers. And then from there you will come up with a listing. There is also a muscle test that goes with this, which is testing the vastus medialis, which I will also show as part of this video. So in order to do the setup, you've determined that you have an anterior medial tibia. So what that means is that the medial part of the tibia has come anterior or gone into external rotation. So we need to do the setup for this. So you can either do this just with a table like this, or you can use an X drop, and the X drop can be a bit more comfortable. The drop kind of supplies the feeling of the joint having somewhere to go, especially for the patient. And so you may choose to use the X drop for this. I know that when I do it, I definitely use the X drop for this. So for this move, we are going to contact the medial tibial plateau. And you're going to use the thenar part of your hand as your contact onto the medial tibial plateau. You're going to pop your stabilization hand on the opposite side of the joint. So you're going to make sure that you are supporting the joint itself. You're not too high on the femur or too low on the fibula. You're right over the joint space. And for traction, what you're going to do is put the foot between your legs, and then you're going to distract the leg downwards or in an S to I direction. So obviously if somebody has an issue with their hip or they have an issue with their knee, this type of distraction may not suit everybody. And that's where you may choose to use the X drop, because you don't have to apply that distraction when you are using the X drop. Or you may choose to just use your activator and place it on there and then put it in the correct line of drive. But for this manual move, you're going to make sure that the person's knee joint is on the table. You don't want the tibia kind of hanging off. For this one, if you're not using the X drop, you want the knee joint on the table itself. Again, you're just going to put the person's ankle between your legs, because later on you're going to apply some traction. You're going to contact the medial part of the tibial plateau, so you want to make sure that you palpate to find the joint space, then come inferiorly so you're just on the tibial plateau. You're going to use the thenar portion of your hand as the doctor's contact, stabilization on the opposite side of the joint, surrounding the joint, distract or lean back, and you're just going to go in an A to P, M to L direction. To be honest, it's mainly A to P, so if you just said A to P, that would be fine. But you're going to thrust just with your contact hand. This one just purely stays at stabilization, and you're going to go down and into the table. The person's going to be obviously quite extended in this position, but you don't need them to contract their quads and go into extension. Just get them to relax on the table. If you did want to use the X drop, this is when you are going to put, remember when we use the X drop, we always put the bone that we're trying to adjust off the edge of the X drop. So we want the tibial plateaus just off the edge. So you're going to need to place it underneath the knee. So you're going to have to find the joint space. So if we just feel through here, on this medial side, I'm not sure if you can see that with the camera, but that's right. We need to move it up a little bit. Cool, so now we've got the tibia just off the edge of the X drop. Same thing, you can just hold the leg. You don't need to apply the traction, but you can just kind of hold the leg in place. You pop up your X drop, take your contact, you can still stabilize on that side, and then you're just going to drop down in an A to P direction. If I demonstrate on this leg, in case you guys can't see the contact too well, you're going to find the joint space between the femoral condyles and the tibia. You'll find the ridge that is the medial tibial plateau. This will often be quite tender if this person does have this listing. You're going to pop their ankle between your legs. You're going to take the contact point with the thenar aspect of your hand. You don't need to tissue pull, but you can kind of just slide onto there. Make sure the knee is securely on the table, stabilize on the opposite side, distract back, and then drop down in an A to P direction. If we were to move on to the anterior lateral tibia, so that now means that the lateral aspect of the tibia has gone anteriorly. or this is what we can also refer to as an internally rotated tibia. This is going to look exactly the same, however you're now on the lateral aspect of the tibial plateau. So same thing, you're going to put the ankle between the legs, use your thenar pad as a contact, find the joint space, so come off the femoral condyles, find the joint space, find the lateral tibial plateau, pop your thenar contact on, stabilize on the medial side of the joint space now, because we're now on the opposites, and same thing, you're going to distract back, pulling the leg S to I, and then just drop straight A to P down. For this listing, you're going to have obviously your motion, palpation findings, but you'll have a weak vastus lateralis this time. So your vastus lateralis goes with an anterior lateral tibia, and your weak vastus medialis is going to go with an anterior medial tibia. And that we can also do is a posterior tibia. And the best way to find this is from our motion video last time, is basically doing the anterior and posterior draw tests. And if you're pulling the tibia forward and it doesn't go, and it moves really easily posteriorly, that may mean that you have a posterior tibia. For the setup for this one, we're going to have the person prone and their knees going to be almost off the table. So what we want to do, we don't need to be in between the legs, we can actually be to the side, is you're going to lift the person's leg and pop it onto your shoulder. Because our contact point is going to be the posterior aspect of the proximal tibia, we can easily get it and tension it with the leg on your shoulder. So for this move, you're going to start with the leg at about 45, so it's resting on your shoulder, and then you're going to take your contact. So the important thing here is that you're not within the popliteal fossa, obviously, because we've got a lot of nerves, blood vessels and things like that in there. We want to make sure that we're just inferior to that, so we're only on the proximal posterior aspect of the tibia. You can use either hand as a contact for this because there is no rotation, so it doesn't matter if you're pulling more with one hand or the other, because you literally should only be pulling in a P to A direction. So start with the person's leg at 45. You're going to take your contact point. You can place your fingers here. It doesn't actually matter which fingers, but you can use the middle two. You're going to take a contact, making sure you're not in the popliteal fossa, but you're on the proximal posterior tibia only. You can kind of interlock your fingers or place your stabilization fingers on top of the others. You're then going to bring the leg up to 90, keeping the foot on your shoulder. You're also going to traction down the table, so in an S to I direction. I need to put up my other leg. And then the thrust is just going to be purely P to A or in an S to I direction down the table. So you're going to pull this way. So the key thing that people forget is starting at 45, taking the contact, making sure you stabilize with the opposite hand on top, bring the leg up to 90, traction a little bit S to I, and then your thrust is going to be S to I down the table. Or you could say P to A, that's also acceptable. So in order to do a muscle test for the vastus medialis, what we need to do, so this would be to confirm an anterior medial tibia, is we need to put the lower leg into external rotation, or you can get the person to externally rotate their lower leg and their foot. Yep, that's good. You can bring them up into a little bit of extension, knee extension, and then what you're going to do just at their lower leg or at their ankles, you're going to try and push them into a flex position, and they need to resist you while maintaining the external rotation. So if you push against me, that's good. So that's your test for the vastus medialis. So the opposite is for the vastus lateralis, where you get the person to go into internal rotation. Yep, that's good. And then you're going to do the same thing. They're a little bit extended, and you're going to try and flex their knee while they're holding the internally rotated position with their lower leg. If this was weak, this would be positive for an anterior lateral tibia. Then the other one we have is the popliteus, so you can relax your leg down. And for this one, you basically just want to try and resist the person going into internal rotation with their lower leg. So you can start them in external rotation and then say, I'm going to resist, I want you to do this motion and I'm going to resist you. So you can kind of apply resistance, and then if this was weak, this would be positive for a posterior tibia.